So let me.
So thank you everyone for the Lincolnshire ground round. Today you have a special guest with us, Professor Manuel Bernard, and the other surname, I'm very sorry for the pronunciation. Is it
Sprekelsen. It's very easy.
Sprekelsen. Yeah. So,
Bernal-Sprekelsen, very easy.
oh,
I do it every day, so no issues.
Yeah. So Prof is one of the eminent rhinologists in Europe as well as the whole world, but just mainly very known to the people in Europe and the UK as well. He's the professor or head of the department in Barcelona Medical School, and we hope that we enjoy his topics today about the tricks and tips regarding to the revision FESS. So thanks again, Prof, for your kind acceptance of our invitation.
Yes, thank you for your kind invitation and for your patience regarding my technical issues. The only thing is you need to allow me to share my screen, otherwise I will not be able to show you the slides.
So is it stop sharing?
Rahman, just make him co-host.
Okay.
Co-host or host, yeah.
Yeah, from the right hand side. Co-host.
From the three points on the right, three dots, yeah.
So put waiting room allowed. Make a host, yeah.
Oh.
Okay.
Wait. Okay. Wait. That's strange, because now I do not see. Well, I'll try to open the PowerPoint, and then you tell me whether you can see the PowerPoint presentation. Can you see it? Can you see the first slide?
Not really.
No, you can't.
No, don't see.
Okay, because by making me host, the sign where I can share the screen has disappeared.
Okay, so how we can manage this, Absalom?
Yeah, it's just should be there. Just the green one, share screen. You can find it.
In mine.
Yeah, I'm wondering why, because the host, only host or co-host can share screen.
Well, it was before. Before it was the sign was there saying share the screen, but when I tried, it said the host needs to give you permission. Now that green is no longer here.
So you already the host. So can you make me the host so I can try to manage it?
And let me know how I can make you the host.
Yeah, there is three dots on the right. Yeah,
that says more.
Yeah, click on it.
Yeah, it's open.
Yeah, so just you can make me a host, so I will try to manage it.
Thing is, it does not say make someone the host. It says participants, invite, copy the link. Wait a minute. Here I am. Wait a minute.
Yeah, just
Wait a minute.
Yeah.
It says share the screen.
Yes.
And now you should be able. Can you see now the first slide?
Yes.
Yes.
That's great.
There we are. So sorry for the delay. I hope it will compensate. The waiting time will compensate by the content. I'll try to go through a lot of slides, which I hopefully will finalize in time, and show you a little bit about what's going on when you do endoscopic sinus surgery. If you go to the literature, at least back 10, 15, 20 or 30 years, every time you were reading the papers, it said that around 20 to 25% of the chronic rhinosinusitis were requiring revision surgery. Well, that is not exactly what's happening in real life, because although here I have added with nasal polyposis, this number 20 to 25% revision surgery was comprehending and was including all chronic rhinosinusitis. If you really go down to chronic rhinosinusitis with nasal polyps, with asthma, and with exacerbated respiratory disease secondary to aspirin intolerance, then these figures go up enormously. Enormously means that you are doing surgery in patients every 3 to 5 years, more or less. If you're dealing with chronic rhinosinusitis without polyps or a simple conditions, then these numbers really go down. So the numbers of 2025s are not real. Usually those patients undergo more than 1, 2, or 3 surgeries. Well, happily, with the advent of the monoclonal antibodies, this will probably change. But well, in any case, you still need to do surgeries now and then, because when you discuss with people who are about to think to start with monoclonal antibodies, I think the ideal condition is to have the paranasal sinuses and the nose clean, because then the monoclonal antibodies potentially prevent polyps to grow back. It's more difficult to reduce a polyposis grade 7 down to grade 1 with just the monoclonal antibodies. So whenever you do then a revision surgery, you tend to be more radical in that surgery. Why? Because we think that the more we open, the more we remove, the better. I'll show you that is partially true, but not always. Also, if you check the success rates after revision FESS, these go down. These go down, and this was published many years ago already. So you're not as successful when you do a revision surgery as compared to a primary surgery. So this is something to keep in mind. And I'll show you a couple of reasons why these revision surgeries are probably not as extended or thorough as we think they are or have been. So why and how should we proceed for a revision situation? Should we do an endotype-driven care? That means if we have that typical patient suffering from asthma, intolerance to aspirin, or exacerbated upper airway disease together with an advanced stage of polyposis, should we then do a more radical surgery from the very beginning, or in a situation where the patient has already had a surgery, should we then do that endotype-driven care? That means that is a severe situation, the condition is extended, and we therefore need to proceed with a more aggressive and extended surgery. Now, that is exactly my question now. Is that surgery going to be more extended? And if so, what does extended surgery mean? Because there is no clear definition. You go to any meetings, you hear people telling you, we're doing a full FESS. What does that mean? Well, probably in my hands, that is something completely different as compared to the hands of others. So there is no consensus about what full FESS means. Some people include a draft type 3 or an endoscopic drill out procedure of the frontal, others don't. So there is no clear definition what that means. What seems to be important, that in those cases with nasal polyposis that have that type 2 inflammation, that the early surgery seems to reduce the so-called biological behavior of the disease. That was found out by one of your colleagues in London who did that study, showing that the earlier we do the surgery, the better the outcomes on the long term. And that is what I mentioned already. What is full FESS meaning? What does radical surgery mean? Does this always include a reboot approach or not? Are we going to use new mucosa from the floor of the nose or from the inferior turbinate to cover denuded bone in order to have mucosa that is not able to reproduce polyposis? Said this, we have to study now what extended surgery mean. Well, this term comes back or goes back to a French colleague of ours called Jankowski, who was talking about the nasalization. That means the connection of all sinuses with the nose. And eventually this ended up in an extended sphenoethmoidectomy, not necessarily including a draft type 3. And he found out that those patients undergoing that radical FESS had better symptom scores on the long term, fewer recurrences, and better endoscopic scores. So that is important to understand because this literature goes back to 2006. Back then, the term nasalization or radical FESS was not considered anywhere else except in France. And this is important to understand because that term has now been uptaken and reused as what we call reboot technique, that is removing all mucosal areas that have the tendency to produce polyposis. So that is important to understand that Valerie Land found out that for those patients suffering from an isolated, purulent, smelly maxillary sinusitis, that the medial maxillectomy was about to be very helpful. And in some isolated cases, I do perform that type of surgery. Basically speaking, this is an endoscopic Calvé look where I remove the whole mucosal layer of the maxillary sinus over or through a medial maxillectomy, whatever that technique now is. The question is, do we include a draft type 3 in an extended revision FESS? Well, that is very interesting to study because most experts would say, yes, yes, of course, because if we open the frontal, there is enough space for the rinsing and the saline solution to go in. But it showed that combining a draft type 3 with radical endoscopic sinus surgery did not yield better results as compared to radical endoscopic sinus surgery alone. And this was published recently. So as I am not such a good friend of performing draft type 3s or frontal drill out procedures on a regular basis, I think that paper made me pretty happy because I rarely do draft type 3, even nowadays. Now, when it comes to revision surgery and to complications regarding the surgery, you have to be aware that you may have complications, of course, and that you have a certain percentage of complications that can happen in a primary FESS surgery. And I'm listing them here and the percentage that I found in the literature. So we studied our own cases many years ago when I was still in Germany. And then you will see that the number of periorbital lesions was much higher than the one published in the literature. Well, the reason I say it always is that usually you do not publish your complications unless they are severe or extraordinary. So we had more periorbital lesions than the mean we could find in the literature. And this again, bleeding, epiphora, diplopia, all temporarily CSF leaks, very low some cases. But which factor may favor the complications when you're doing surgery? First of all, massive polyposis, because you are less able to see the operating field. Revision surgery is a complication, is a risk for complications, because I will show you in a minute what happened. More extended surgery is always also putting the patient at risk. Then the right side, always be the first or a revision surgery, because you are crossing the instruments with a hand. If you're left-handed or right-handed, that makes, of course, a difference. Then it's the other side. Keros type 3, and particularly the more horizontal or horizontalized situation of the lateral lamella. I will show you that back then. The existence of Onodi cells, bony dehiscencies, be it on the carotid, be it on the orbit. Expert surgeon, with the exception of blindness, your patients are more at risk of suffering the complications in the hands of expert surgeons because they think, I know everything, I can risk myself to open that last cell that eventually wasn't a cell. This is very old. When we started, there were no CT scan accessible, and that, of course, increased the risks. General anesthesia, because patients are unable to complain, they have no pain, they cannot tell you, wait a minute, I'm having pain right now, peri-orbit or the dura would be painful. And then in cases the operating field is bleeding a lot, there has been a lot of studies regarding the increased bleeding, reduce the recognition of landmarks, and then you are lost. And then particularly instruments can also be responsible for complications, although it's always the fault of the surgeon, not of the instrument. But for example, if you perforate the papyracia with a Blakesley forceps, you see the fat, you open the Blakesley and you withdraw the Blakesley. It's different than if you're doing the same situation with a microdebrider, because then you see what is fat, but the fat is already suctioned into the microdebrider. What are the complication rates in FESS? And then we studied that some years ago. Revision FESS has a higher rate of complications compared to primary FESS, and that was statistically significant. Also, the more extended your surgery has been, the higher the complication rates compared to limited FESS, also statistically significant. Now, which are the documented findings once you start a FESS? First of all, lateralized middle turbinate. That's the most important and most frequent finding in revision phase. Incomplete anterior ethmoidectomy, retained Aganasi cells, incomplete posterior ethmoidectomy, and retained uncinate. And this was published a couple of years ago, as well as scarring of the frontal recess. So expect this to be your real world if you start a revision phase. Now, what are then your surgical challenges in revision phase? First of all, be aware that the ethmoidal space is narrower than it was before. And the reason is that even if you have preserved the middle turbinate, it always gets a little bit more lateralized and the space of the ethmoid grows smaller. Be aware of that. Sometimes you have missed the natural ostium, the maxillary sinus, and then you see an opening and say, hey, maxillary sinus is open, and that is not the natural ostium. You really need to go in with your backbiter and then palpate with the backbiter to see whether the natural ostium really has been opened in the first procedure. Again, when you are dealing with patients that are undergoing a chronic procedure or a chronic condition of inflammation and infection, you will find that you may have increased osteitis and osteoneogenesis. And what is that condition? Well, it produces a condition that when you are trying to open a cell, or you think it is a cell, the bone is so tough and so hard that then you stop and say, wait a minute, what if this is not a cell? And that cell keeps there and remains in the paranasal sinuses. And that is the reason, because the bone in that area starts to get harder and thicker. And you really need force to open smaller cells in the posterior ethmoid that have never been opened. And then you notice that the bone is pretty thick and hard. And this can or could be such a situation where you see that you have osteoneogenesis in the anterior and posterior ethmoid. This can be a very tricky situation and very difficult to deal with during the surgery. Of course, all the tissue that is surrounding that osteoneogenesis is more fibrotic. And then you do not have no longer that translucent polyps. You have really fibrotic, tough polyps that even microdebriders have difficulties to really suck and remove. And then again, you have no longer regular landmarks, and that is making things a little bit more difficult, particularly if these landmarks involve the anterior ethmoid and occlude the opening of the frontal. So this is such a situation where you see, yes, the middle meatal antrostomy has been successful, but you see there are a little bit of infraorbital cells that have not been opened, and the frontal is fully open. Then you see the sagittal plane, and you see that the frontonasal beak here is really an impediment to reopen that area. In this situation, of course, I would suggest drill that nasofrontal beak away in order to be able to open the frontal proper. So, surgical challenges. You cannot find the frontal, for example. Which options do you have then? Well, that strongly depends on where you are and what you want to do. If there is no disease and the patient has no symptoms, leave that frontal alone. Or if you're in presence of an expert, then ask the expert to help you in order to open the frontal outflow. And if should you have navigational systems, well, the American Academy does recommend a navigational system for revision surgeries of the frontal. I have seen, particularly in France, the trick of to refine from outside the frontal on both sides, then rinse with saline or whatever, and to then from endoscopically follow up the outflow tract and then remove what is around that tract in order to make that patent. That is a good trick. I have used that once in my life, but that was it. So how can you improve anatomical orientation in revision situations? Well, first of all, you need to look for the most stable landmarks. And in such a situation, I would suggest to have not only the coronal, but also the sagittal, and particularly for the frontal, the sagittal scans that allow you to assess exactly where the problems are, which cells have been left over from the first or the other surgeries previously, and how does the frontal outflow tract look like. So check then if the papyracia may have defects, check the sphenoid, particularly if there is an onodi cell, and how the optic nerve and internal carotid artery are bulging into either the sphenoid or the onodi cell. Take care of the Keros classification, but particularly, as I mentioned before, the angulation of the lateral lamella. Then check the anterior ethmoidal artery in the CAT scan already, and the anatomy of the frontal recess. And particularly the choanal border endoscopically, because the choanal border is the most stable anatomical landmark unless you're dealing with a choanal atresia. And then expose additional landmarks during surgery. Why so? Well, Wolfgang Graf regularly exposed the lacrimal sac before performing his draft type 3. And in such a situation, he always knew where to go. That is an option. Or sometimes orbital FELP, not on purpose, but sometimes when you see it, orbital FELP is orienting you a lot and says, well, this is my lateral limit, and use it. Okay, that is important to understand. And even if the middle terminate is missing, you can draw an imaginary picture of where that middle terminate has been in order to give you an orientation where to stay. And I use that frequently when that has been the case. And eventually, you may use, of course, the navigational system. I was mentioning about the lateral lamella. This is the lateral lamella. The steeper it is, like in this situation here, the least is the risk of perforating is. The more horizontal it runs, the higher the risk of perforating it and creating a CSF leak. Here you see two situations where I needed to expose the orbital fat superiorly in order to identify the frontal, which was completely blocked. And here I have a little bit of fat in the infraorbital area, which was helpful to identify all the other structures. whenever you have the situation of exposing the fat, use the trick of pushing on the orbit from outside and check that endoscopically, because then you will see how it moves. I do that regularly, and particularly in revision cases. Of course, if there is fat in blood, it looks like a tomato soup sign. And if you took a biopsy, it floats in saline, okay? But this is the risky situation where you have such an orbital defect if you're using microdebriders. The microdebriders are very quick in removing fat and also the medial rectus muscle, okay? Whenever you have fat, do not aspirate, do not reintroduce, do not cut the fat, do not coagulate the fat, okay? Important. Tell the patient not to blow the nose after the surgery, and particularly do not sneeze with the mouth closed, because both situations may end up in an emphysema. And then you can discuss whether to prescribe or not antibiotics. When we do orbital decompressions for Basedorf-Graves conditions, we usually do not prescribe antibiotics. But if you're doing surgery in an infected area, you may. Then, anatomical landmarks you have to identify. Onodi cell or sphenoid cell. The definitions may vary depending whether it is an anatomist or a surgeon providing the definition. For lung, the optic nerve should be exposed in 180 degrees to be called an Onodi cell. For Stamberger, just the appearance of the bulging of the optic nerve was already an Onodi cell, and that is why the difference is in percentages. Remember that the thickness of on the internal carotid artery is 1 millimeter, somewhere down there, and you may have dehiscencies in a certain percentage. Also, the optic nerve can be dehiscent, as we can recognize here, okay? And then whenever you see on the CAT scan, like a window, a picture on the sphenoid sinus, you know already that both superior windows or areas are suprasphenoidal cells, namely the so-called sphenoid-moidal or Onodi cells. Navigational can be very helpful, of course, but do not rely on navigation to perform or take millimetric decisions. That does not make sense. Navigation is good to confirm what you already know, not the other way around. Okay, so be aware, because you need a learning curve to use it. Although the use of navigation does increase your own learning curve in doing surgeries, it does help for anatomic orientation. There is no literature recording that there is a change in the complication rate. And also, if and these are quite old literature studies on that, it may give you, as I mentioned, advantages in the orientation, but it does not reduce your stress during surgery. We tested this with a very nice study that was published a couple of years ago. Now, how do you do the surgery in revision FESS? Well, the first thing is you change usually the directions. You try to identify the most stable landmarks that are identifiable with your endoscope. And usually that seems to be the choanal arch. That is the most stable anatomic landmarks. From there, you go upwards. You identify the sphenoid sinus. And from there, you come anteriorly and remove the posterior and then the anterior ethmoidal cells. That is important to understand. It may be helpful if you first remove the polyposis in order to identify all other landmarks, for sure. And the more landmarks, then the better the orientation. And as I mentioned, sometimes in revision FESS, it is better to come from posteriorly to anteriorly, okay? So, as mentioned by the American Academy, you can use navigational systems for revision surgeries, okay? So what happens with the middle turbinate and the synechia formation? Well, the lateralization of the middle turbinate is the most frequent, I would say, complication after FESS. And it doesn't matter whether you're using spaces or no spaces, because the event of a lateralization, as studied by Weber, who was a pupil from Wolfgang Graf, occurs between 2 and 3 months. The only thing you can prevent from lateralization is when you do the bulgarization, or you put some sutures between the middle turbinate and the septum. That is helpful, okay? Yes, it may be an impediment for drug delivery when you have a lateralization, and all this has been studied thoroughly. So how to handle the middle turbinate also in a revision case? Well, chop it away. Yes, that is an option, particularly if there is a lot of polyposis around it and within it, okay? But remember, it's a useful landmark still, okay? However, if you remove the middle turbinate, at least subtotally, there is no difference in an outcome. There is no difference in drug delivery of the ethmoid, okay? And importantly, if you do a subtotal resections, there is no difference in synechia formation. Still, that little lump that you remain can lateralize and obstrude and occlude the frontal outflow tract. So how do we handle then the middle turbinate in revision cases? Well, this guy studied 509 with and 597 without resection of the middle turbinate, okay? And he concluded that a partial middle turbinate resection was associated with less synechia formation and fewer revision surgeries. And note, not associated to complications, okay? So a partial resection, I would say, of the head and the inferior third is probably helpful. And otherwise, you can do still the bulgarization, scarification of the mucosa of the septum and the medial aspect of the mucosa of the middle turbinate, or you put a stitch through the septum. Another practical advice is, well, there may be, to avoid worst case scenarios, of course, you have an inadequate indication that is not unfrequent. Make sure that when you indicate a surgery, that really is disease first, and second, the patient has complaints. Just the disease in the CAT scan does not justify a revision surgery or even a primary surgery. The other question is, how old should or can be the CAT scan? Well, the closer to the surgery, the better, okay? But if the patient has had a CAT scan 6 months ago, and then you see that the polyps are growing, you don't need to perform another CAT scan that is an unnecessary irradiation. Also, having or lacking the proper instruments to do surgery, that is important to understand. Also, having a lack of knowledge in the anatomy, be it radiological anatomy or surgical anatomy. You need to go back, you need to stop sometimes, go back to the CAT scan and assess whether you are at the right place and whether the CAT scan is telling you that there still are cells open to be opened, or whether you have really removed what needs to be removed. And then you can go back to the patient. Then lack of confidence, then you will, of course, leave lots of cells inside. That is probably better than producing a severe complication. But as we know, and I mentioned that initially also, the excess of confidence can lead you into a worst case scenario. Some practical advice to avoid this worst scenarios is, whenever you have to perform FESS in small hospital or as an outpatient procedures, you can do that. Particularly, it's a primary FESS. But if you're going to do advanced surgery, an important skull-based revision, because the polyps are very extended, there is osteogenesis, and you need even to drill this area, you better make sure that there is an expert close to you. Otherwise, I would not recommend to do that surgery. Important, be prepared to resolve not only the complications together with neurosurgeons or with ophthalmologists or even other colleagues. Be aware that whenever you call an ophthalmologist because you have an orbital hematoma, the ophthalmologist usually is lost. You know better what to do as compared to ophthalmologists, but from a medical legal point of view, it is good to have informed and invited the ophthalmologist to help you in that situation. And then again, do not hesitate to call an experienced rhinologist whenever you run into problems here, okay? And then again, anatomy, anatomy, and anatomy, as the former anatomist Lang from Germany was saying always. When you do revision surgeries, be aware that there is a tendency to perform more extended surgery. The more extended surgery you are, the higher the risk of complications. Expect changes of the regular anatomy, more difficult to identify or to expose landmarks. The higher complication rate is because you're doing a revision surgery and because your surgery is more extended. Be aware and remember that you're treating a benign disease, meaning that don't put the patient at risk if this is not necessary. It is preferable to have a remnant cell or a remnant polyp somewhere in the corner than to end up with a major complications. And then again, this is putting yourself at risk. Seriously, try to avoid this. And should you have further questions, I will be pleased to reply or answer them. And otherwise, I came to present my book, of course. Thank you very much for your attention.
Well, thank you, Prof. Really amazing. And I think everyone enjoyed it as well. So anyone have a questions, he can just unmute himself and just put the question on. My question is regarding myself. I'll start with myself. Is regarding to the laminar perforation injuries. So you think that if you breach the laminar perforation and you get the fat, it just you don't like to put any support, any primary support in this case.
No,
You just
no
leave
need.
it there and just
leave it as it is. Don't touch it. Don't pull. Don't put it back. Leave it as it is, just like that. There's no need. I mean, if you're doing an orbital decompression, okay, where you have an overproduction of fat usually, then you can remove a little bit of that fat. But in a normal case for FESS, you don't need it. Leave the fat there. It will scar, whatever. That's it. No need to do anything.
No push, no support.
No support. Only support if you're dealing with the infraorbital area and you think that the patient may end up with an enophthalmos. But that is a situation that should not happen in a revision case, or not even a primary case, that you have removed so much from the infraorbit bone that the patient has an enophthalmos. And that situation, yes, then the eye needs support. In the medial aspect, no support needed.
Anyone else want to ask? He just unmute himself.
Sean, please. In terms of the CSF leak following a skull-based breach, what is the best material to graft if this happens?
The loudspeaker was not good enough. You mean CSF leak?
CSF leak due to breach.
Okay. Yeah. That strongly depends on the location and on the size of the defect. So usually, if we do a FESS, what may have happened is that with a Blakesley, you have opened or the roof of the ethmoid. In that situation, if the size is about a couple of millimeters, which I cannot translate in British in British sizes, and then if you put some fat inside, that's fine. So it's a black path technique, okay? And over that fat, you can then use mucosa from the middle turbinate, for example, to help in mucosal regrowth. If the defect is larger, I would try to dissect the dura and put fascia lata in between the dura and the bone, and then cover that with a mucosal graft. Should the defect be in the cribriform plate, again, it depends on the size. If the size is small, abdominal fat as a bath plug technique is the best. if the size is small. If you have created a larger defect, then you can think of any other techniques that have been published: fascial lata, rotational mucosal flap, free grafts, whatever. What works best in your hands.
Thank you.
Thanks, Prof. Anyone else? I don't know how as usual, we know that our grand rounds have 1 CD point from the Royal College of Edinburgh, but I don't know how to do this over the Zoom. So I'll advise everyone, please, to send me an email and I will reply to each of you with the certificates. This is the only way. I'm sorry for this, but this is just as an announcement. Anyone else that would like to ask question? That's fine. So again, thanks, Prof, for your time. Really appreciate it.
You're welcome.
We cannot
Anytime
say
you like.
anything. Yeah, no, I know your time is very, very condensed, but really appreciate it. I think everyone was getting benefit from that. We are recording it as well for everyone who wants to watch it again. Thanks again for the time and for everyone as well.
You're welcome.
Thanks.
Bye-bye.
Thanks, Prof.
Anytime you like, let me know.
Yeah, sure. We will have another one, but give you like 6 months or more just to get rest. You
No
know,
worries.
the other 3 topics will be really interesting as well. Thank you. Thanks.
Okay, bye-bye.
Thank
Thanks
you.
for the
Thanks,
invitation.
bye.
Bye-bye.